Hey, everybody, it's Kevin Henry, editor in chief for drbicuspid.com. Thanks so much for joining us for another podcast. And I'm thrilled to welcome in Dr. Ashley Clark.
Hi,
Dr. Clark,
everybody.
today.
I'm doing well. It's second day after daylight savings, so we're all dragging over here a little bit. But other than that, we're all right.
Well, I'm glad you made it for the
Yeah.
podcast because I met you at Chicago midwinter, and I'm really excited to talk about something I know you're very passionate about today. But before we dive into that, I'd love for our audience just to know a little bit more about you.
Okay. So I'm Dr. Ashley Clark. I'm a board certified oral pathologist. I own a private practice laboratory here in Indianapolis, Indiana, and I've been doing that since 2022. Before that, I taught in several schools and many different capacities. I was associate dean, but I've been, residency director and all sorts of things in academia. So this venture into private practice has been a little bit different, I would say. And then I also serve on a tumor board here in Indianapolis, where I see a lot of patients who undergo these oral cancer surgeries, and then I lecture. And that's about it. Is that enough?
I think that's plenty. Keeps you busy for sure. And I think those lectures is where you're trying to get across something that, like I said earlier, you're very passionate about. And that's that dentists and dental team members, the biopsies aren't happening enough in the practice. Is that correct?
Yeah. So to sort of put it in perspective, there's two of us here at Camp Laboratory. That's the name of my lab, Camp. Cutaneous and maxillofacial means oral and skin. And my partner is derm and I'm oral. So I see all the oral, he sees all the derm. I have about 300 contributors. He has 5. We see the same number of specimens. So if something in dermatology needs a biopsy, they biopsy it. And a lot of them do it themselves that day, which is a little bit different in dentistry. But I see so often in dentistry, I don't want to say we're scared to biopsy. I think that we like our patients too much and we don't want to scare them. We don't want them to have to pay for this extra procedure. So we're sort of hesitant to biopsy. No one ever died of an incisional biopsy, but I see people every single Wednesday at that tumor board that are going to die because they didn't get one. So that's sort of the message that I've been trying to get across, that if you don't know what something is, biopsy it. Don't guess, just get a biopsy. We can't be scared to say exactly what our patients need, and we can't treat something before we diagnose it. And sometimes the only way to diagnose it is with a biopsy.
And I know one of the trends right now on social media is to show something and say, "What is this?" and guess
Right.
what it is and everything. And from you and I talking a little bit, I know that kind of drives you crazy because
It
you
does.
yeah, yeah. Why? Tell me.
Yeah. So, first of all, lots of bad answers, like terrible answers. You should not crowdsource your pathology. People will speak with I don't know if the word is bravado, but they will speak very confidently and they're just wrong. And so that's the main thing. But the second thing is they're just guesses. If you want to know the answer, do a biopsy. If you don't know how to do your own biopsies, it's actually really not that difficult to do, but you can refer to oral surgery, you can refer to a periodontist. Those folks are very comfortable doing incisional biopsies, and that is really the best way to get a definitive diagnosis, is to just biopsy it so you know how to treat it, so we're not guessing. And this doesn't apply to everything. If it's like in planus, I still biopsy it if it's symptomatic, but those things don't always require a biopsy. But white lesions on the gingiva that are sharply demarcated, we should be biopsying those at a far greater percentage than we are. And we don't, because they look like nothing. And then they sit there and then they turn to cancer. And that's what I see all the time. Like, I see the mistakes that are made. So I'm really passionate about not putting down the dentist that made the mistakes, because we're all making them, but trying to learn from them so we can change course for the future.
What are some of the biggest questions you get asked after your lecture's over with? Because I know nobody raises their hand in the middle of it. They all want to
Yeah.
wait and talk to you afterwards. Is it about the fear of finding the cancer, or what is it that you often hear about?
I think people maybe sometimes are a little bashful that maybe they don't know what they should be doing, or people will often say, "Can I ask you this? I'm sorry, oral path wasn't my best subject." I don't think there's any need to be embarrassed that you don't remember 100% of things from 15 years ago. I often will say it like this: I don't remember how to place a resin. I don't remember how to place an amalgam, and I'm not joking. I don't know how to do it. I haven't done it since 2010, so I've lost that skill set. I would need your help if I needed to place a resin, and I say resin and amalgam because those are very simple procedures, so people know, like, if you don't and you don't think I'm dumb, right? So if you don't use it, you lose it. So it's okay to ask for help with oral pathology. But if you're going to crowdsource your oral pathology, look for the people who have the credentialing and that aren't guessing. And also, when in doubt, cut it out. If you don't know what it is, the best way to get a definitive diagnosis is to biopsy it. And we shouldn't be treating things without diagnosing them anyway. So, and sometimes the only way to diagnose these things is to do a biopsy. We just don't biopsy enough, certainly.
And do we need to improve our communication skills if that biopsy is going to happen? And I feel like that's when maybe you bring in the dental assistant as well or another team member to kind of make sure that the patient doesn't jump to conclusions. Or am I reading things wrong?
Yeah, no, I mean, we're not always, not every biopsy is because we think it's cancer. Sometimes a biopsy is because it's a benign tumor and it's not going to go away until
Yeah.
we biopsy it. Mucocele is a great example of that. A mucocele will never go away unless it's biopsied. So I just think at this point in my career, I would just be really matter of fact. This is X. I think, here's what I'm seeing. Here's what I think it is. We're going to biopsy it and figure it out. Or, just this needs a biopsy. I don't think we should ask our patients their opinion on these things. Of course, a patient can deny biopsy if they want to, and that certainly happens. And that's something that people struggle with a lot as well. But we just cannot be afraid to say, this doesn't belong there. I don't know what it is. It needs a biopsy so I can figure it out. And, the joke I make in my lectures is I have quite literally never left my dermatology appointment with all of my skin.
Yeah.
He will always, if something looks even remotely suspicious, just cut it off.
Yeah.
And we should not be afraid if our patients need it. Not obviously not everybody needs a biopsy, but if our patients need it, we shouldn't be afraid to say it.
And I'm glad you said that because that was going to be where I was going to go because you mentioned your colleague there on the derm side, and I think skin cancer gets such a reputation, gets talked about so much, and I
Yeah.
don't know we talk about oral cancer enough, to be
Yeah.
honest with you.
Oh, certainly. So for every single squamous cell carcinoma of the oral cavity, now these are the HPV negative ones. The HPV positive ones are in the throat. So your tongue cancers, your floor of mouth cancers, your gingival cancers, every single one of those cancers has a spot there before the cancer comes up. And 85% of the time, that spot is a sharply demarcated white lesion called leukoplakia. So if we treat leukoplakia appropriately, we should be able to lower the oral cancer rates. But there's been studies, there was a group of researchers that followed 5,000 people for 8 years, and they found out that fewer than 5% of those that got oral cancer did the dentist catch the precancer. And I don't know if that's a dentist issue that we're not, or hygienist issue that we're not catching these precancers, or if it's a public issue because we're not talking about these things enough and the general public doesn't understand they're getting a cancer screening as well when they go to the dentist and dental
Right.
hygienist. They forget their mouth is attached to their body sometimes, right?
Yep.
So both of those things can be true. And, the other thing is you mentioned skin cancer. The number one skin cancer killer is melanoma. And in the oral cavity, anything that's an isolated pigmented lesion, unless the patient can see it. So if it's on the lip, the patient can see it, they know it's not changing. So if it's on the hard palate and if it's one isolated spot, if you can't prove it's amalgam, you have to biopsy that. It's required. And people are like, oh, it's probably an amalgam tattoo. It's probably melanoma macule. And we cannot afford to guess because, like I said, melanoma is the number one skin cancer killer, right? Stage 1 and 2 skin melanoma have a 99% survival. It drops to about 68 for stage 3, drops to about 28, 29% for stage 4. Overall, oral melanoma is less than that. It's about 10 to 15%. So we can't wait to see if that spot changes and then biopsy it because then it's too late. And so that's another thing that sort of drives me batty as well is we're not biopsying these isolated pigmented lesions. And the reason we're not doing that is because 99.9% of the time it's fine, right? And so you get away with it for so long and you get this confirmation bias that, oh, I don't need to biopsy it. I've never done it before and everything's been fine. But we can't wait to see if it changes because that really could be too late. And we don't care what it is. We don't care if it's a amalgam tattoo or a melanotic macule. None of those benign things matter. We're just trying to make sure it's not melanoma. Yeah, so it's just sort of we have I think a culture in dentistry where we just don't biopsy enough.
I mean, it's some really good things to think about. And I know that you're out on the lecture circuit. You're talking about this a lot with a lot of
Yeah.
dentists. And so I want to make sure people know if A, they don't see you out there, where can they reach you? Where can they learn more? Maybe ask some questions.
Well, sure, yeah. So I have a website and it's pretty easy. It's just ashleyclarkdds.com. There's no E on Clark. That gets even in the same email, sometimes people will spell it differently. But ashleyclarkdds.com, you can submit questions that way. There's on-demand courses on there if you want to brush up with anything, or you can just contact me directly through the website, and I'm happy to help anybody who's listening.
So we're going to put that in the show notes, as well as if you're watching this on drbicuspid.com, the link is in the article. Very easy for you to get a hold of Dr. Clark and ask those questions and brush up on those oral path skills. So, Dr. Clark, thanks for your time and thanks for your passion on this. I really do
Yeah,
appreciate it.
thank you. It was so nice to connect with you in Chicago. Thanks for having me.
I'm glad I ran into you, and I'm glad
Yeah,
that you,
yeah.
seriously, from the moment I met you, I sensed that passion, and I was like, we got to have her on the show. I'm so glad you came on.
Intensity, passion, whatever.
It's all good. So again, thanks to Dr. Clark. Thanks to all of you for watching this episode of the drbicuspid.com podcast. Until next time, it's Kevin Henry, editor in chief, signing off. And as always, wishing you nothing but success ahead.